Hi, everybody. Welcome to our European webinar. The series this year is on supervision and training. I'm Oria Tishby. I'm the president of the European chapter. And I'm really happy to introduce Henriette Löffler-Stastka. She's a psychoanalyst and a psychiatrist. And I said that's a rare combination nowadays. She's in the Medical University of Vienna, and she's the dean of the postgraduate training program. And your title is Clinical Competence-Oriented Approach in Psychotherapy Training. And welcome, Henriette. Thank you. And just let us know how you would like to proceed, like you asked me before.
Yes, thank you, Aurea, and thank you all, your organizing team, for the invitation and for the possibility to talk in this webinar. And I mean it really that we should talk about. So if you have questions, I see some colleagues I'm very familiar with already, so we know each other. Some I know not so till now, but maybe we can talk and discuss more. So if someone has questions, please step in and interrupt me. This is not a problem for me. I want to, for an overview, I want to go in this direction, that I wanted to say a few things about why in Vienna, but not only in Vienna, we go into the direction towards a competence-oriented approach in training. So the Spree-Stat study, for example, Orlinsky was conducted, and all the group around Orlinsky, so Armin Hartmann and Thomas Schröder and Ulrike Wilutzki. I was a part of the group for mid-career counselor for this function, and there we also saw that the worldwide trend is going into this direction, that for psychotherapy training, competence-oriented approach is the best. And then I want to go to some points concerning quality assurance and admission procedures, and how to identify and address the learning gaps. So how can we see when a candidate is not so well prosperous developing, or he is very good developing, then what can we do, or what can we address? And why is clinical teaching so important? Why is the patient safety, and why is also in our view in Austria we installed now an appropriation exam due to the new Psychotherapy Act to 2025 to 2024. Why is this necessary? And the ongoing research, I want to always point at these topics also.
Okay, I just wrote that if you have questions that you want to put in the chat, you could either stop Henriette, or you can write in the chat and I'm following the chat. Okay? Okay.
So why competence-oriented approach in training? At the left side, you see the Narrenturm in Vienna. And it was in the 19th at the end of the 19th, 20th century that we did not know how to treat people. But as you can see here, this is the Berggasse 19. It's the Freud house, so where Sigmund Freud was practicing, and this was the beginning of the training program in Vienna. It was the Mittwochabendgesellschaft, and there always was the Jung team, so the conjunction between healing and research. So in the psychotherapeutic session, in the hermeneutic circle, the psychoanalysts and the psychiatrists, they gathered the basis of a theory, and they could consider it in the clinical working situation and provided then a clinical theory. And the next step in the further working through, it got a scientific theory. So it is, in my view, very important to have the patient in the focus and work in the clinician's tradition, as there is also another problem concerning the prevalence of anxiety, affective disorders, somatic stress disorders. In Austria, for example, around 24% are affected, but only 3% are in psychotherapy. And this costs a lot. For example, for around 4.3% of the gross domestic product go to the subsequent costs of mental illness in Austria. And this is going on and getting more. And it's when you go into the conjunction to the somatic diseases, there you have the normal regulation of cortisol and amygdala and prefrontal cortex. But if this does not function, and melancholic depression, according to a disequilibration of amygdala or cortisol and not functioning prefrontal cortex, you have this situation that interleukin is and the inflammatory, the para-inflammatory, the cortisol is high, and you have visceral fat, you have latent diabetes. So the multiple effects on the organisms are to be kept in mind. And we also have to think of the patient concerning his psychic functioning. So this is the best we are functioning in normal situation. We are in the situation that we have an integrated self, and we can see others as integrated objects. But when there is stress or a personality functioning problem, and there is splitting dominating, or even if there is fragmentation dominating in the psychotic psychic structure, there is a problem that we have to develop a psychotherapy that is able, a treatment, a psychotherapeutic treatment that is able to grasp either the psychotic structure or the borderline structure, or if you want a neurologic structure, and more or less maybe some psychosomatic point of disequilibration. Or you have to go, if you have genetic deletions, for example, you have a very complex situation. So this is more and more complex. So this, in my view, is a very central thing, that you always have to have the clinical situation have to have it in mind, and you have to build up your training program around this clinical situation along the Jung team between research and healing. As you all know, we had a lot of concepts already. There was the psychoanalytic concept. There was then I think I do not have to explain the 4 schools to you, but or the history. But I think that concepts are very necessary, but they have to be validated, and also in training programs, the didactics and the situation has to be empirically validated, as for example, Marianne Leutzinger-Bohleber showed in this picture that if we have a training concept, for example, we can go into the psychoanalytic situation and try if these individual theories about the treatment and the development of training programs and the clinical quality circles are effective, but there is also the necessity that there is an interdisciplinary research going on concerning the point that training should be effective, and what do we have to take into account, that psychotherapy is embedded in a very in a situation where psychosocial care is interdisciplinary created. There are social workers, psychologists, psychiatrists, sociologists, and all these groups are working together in psychotherapy, and this has also be kept in mind when you build up a training program. I also want to remind you of the generic model of psychotherapy, which was published by David Orlitzky in 1994 already, where he pointed at the circumstances, what you have to go into when you do proper research, and also proper research concerning the therapist's development. So what we know is that we should provide a training that makes the candidate be able to build up a good therapeutic relationship, which belongs to the very effective forces explaining about 30% of the variance of outcome of psychotherapy. And we should provide techniques, but we also have to go into the training or the development of the therapists concerning their attitude, their development of capacity of reflective functioning, for example. And in this sense, I want to remind you on von Nicky's mentalized affectivity, because the main thing for a child is that a caregiver is able to provide an effective resonance, a reflective functioning, and he or she should provide a reaction, so an expression of metabolized affect, so that the child and maybe also the patient can develop a psychological level towards his or her brief emotional constraints, physical experience, pain, emotional events. So the key factor is the reflective functioning in psychotherapy training, in my view, and how to develop this reflexivity has to be fostered in the training, because if you have this problem, that when there is no point of contact, no resonance, no affective holding, no reflective functioning, no alpha function according to Bion, there is no reaction. So the patient or the child will not be able to learn something about a meaningful understanding about his or her affects, pain, painful situations, and it will be this will not be very helpful. The second point, why it makes sense to go into a competence-oriented training program is that we know concerning the memory vulnerability that we have in, for example, working with traumatized patients, that in the phase of the encoding of the trauma, the memory is vulnerable, but also in the reactivation, in the reconsolidation phase, when the traumatic event is reconsidered or recall, when we recall the traumatic memories, and there we can intervene. So we have to train our candidates to be as good as they can and to go into an effective in the interaction of the psychotherapeutic duade. You have to point at the effective constraints and the recurring patterns at the moment of the interaction, the corrective emotional experience, when you want to call it this, in this direction, can be helpful to develop a procedural long-standing and sustainable change in patients. We did look into the Munich psychotherapy study, and there we could find that reconsidering the dreams and fantasies of a patient and the memories or the reconstructions of the childhood, and if they were if these topics could take place in the psychotherapeutic sessions for depressive patients, we found that, for example, here in this group, also 3 years after termination, so 3 years at the 3-year follow-up, the analytic group was going down with her symptom load. So affect-related interventions have to be taught. We have to train our candidates that they can reach their patients effectively. We know that the emotional expressions that they are showing up in the intersubjective field, and it is associated with the mentalization capacity. And we also know that these patterns are socially transmitted. So therefore, the therapy should focus on the effective interaction patterns. We know this. We also did a study concerning microexpressions. So, for example, what is interesting that in the way when the psychiatrists were confrontative concerning the contempt affect, the facial affect concerning contempt, when they were confrontative about these affects towards the patient and not only supportive, the working alliance was better than when staying only in a supportive manner. I think you all know that the effective tone is very necessary. And now I wanted to come to the point that I want to talk about the admission procedures, or the how to build up a quality assurance admission procedures, and how to concretely implement such training, what I talked about till now, what I was requiring, that we concentrate on the patient and etc. But are there more questions till now? So maybe I only wanted to stop for the first thing, because I'm now. Other questions for you? Yeah.
I have a question, Henriette. I hope it's okay. When you showed these facial expressions, and is this something you teach trainees? I mean, how do you teach them to be sensitive to different expressions or affects, or is this something that you will explain? Because I kind of like that picture and the different emotions. So I was wondering.
Yeah, this is thank you for this question, because this is exactly what I wanted to step in now. So yeah, the training for really grasping these affects is very necessary to be trained in a simulated situation for the candidates. So they have, for example, we organize the teaching in small groups, and the training is practice-oriented, patient-centered, and it includes sufficient personal reflection skills. So we build up the qualification profile, and each course has its own learning objectives. And for example, when we train the candidates to grasp the effect, accordingly to make a meaningful intervention, we have a simulated patient, and this simulated patient is trained in the Stanislavski method, for example, or in the Löffler-Stastka method. So he's very reactive also on the conscious level, and can react as the real patient who he is playing would react in the situation of the exploration, for example, or in the situation of the crisis intervention, or what is the learning objective of the course. There could be different learning objectives, and this is very necessary to have a very good simulated patient, because when we want to also train the candidates to be aware of their countertransference, for example, we have to have a simulated patient who is not only role-playing like a script, like going into a script and talking like a script, but he has to be the patient. And this is provided by, we have some simulated patients, so simulated patients who were trained in Max Reinhardt seminar in Vienna. So they learned this Stanislavski method and the Löffler-Stastka component. And then we give the feedback, and also the simulated patient gives feedback from the view of the patient. So not his own what the simulated patient thinks, but the simulated patient has to give feedback from the view of the patient. And this is helpful for the students. And you have to have small groups. So this is very interesting that we also only in 5 person in so there are very small groups, and they have their talk videograph. They have a we take a videography, and they can look at their own exploration or crisis intervention, or and they reconsider and can then think of further how to get better.
And what are these patient simulation based on? These are real cases?
Yes.
Or yes.
Yeah.
Okay.
These are severely depressed patients, suicidal patients, substance use disorder. So the main somatization, a patient who had a somatization problem, alcohol dependency, anxiety. Okay. So, but also schizophrenia. Also, how you have to get in contact how schizophrenic thought disorder is experienced, for example. So also these severely disturbed patients are provided.
Okay. I see, Denise, you have a question.
So I have yes, a comment. Considering how to develop these caring capacities, I like to recall two papers, two pieces of research. One in Germany, when they studied 360 trainees and found that along training, they got better technical skills or intellectual knowledge, but became less and less empathic, because the supervisory relationship was very hard and punitive. And the other is research we did here, 10 years, 1,500 caregivers. And this was supervised by David Orlinsky and by Bernhard Strauss. And the basis for this, and this is what we later took for training in therapy, is that it's not only patient-centered, but trainee-centered, in the sense of providing care so as to may have an implicit knowledge, an implicit acquisition of caring by being cared for. And this is what you said, small groups, for example, are essential. We have group supervision and this atmosphere of caring. So I wouldn't say it's patient-centered, it's patient and trainee-centered.
Thank you very much, Denise, for this comment, because this was the reason why we implemented some kind of empathy lab and a learning diary. So our students are writing their diary, so their learning diary, after each course. So they reflect on how they experienced this course, or how they reflect on their own how the supervision was, or how the session with this supervisor was, or with this group experience, and etc., etc. And this goes into a diary, and a learning diary also. And they can reflect, and then they have the opportunity, if they want. They have a peer group. They have only 3, so it's a very, very small group. Only 3 candidates are together, and they can first discuss in a group, so in peer, only without a supervisor, or without a training. And they can then, of course, also talk to their teachers or to the supervisor, so to have this permanent reflection. And this is called Empathy Lab. And the students like that very much, because they learn the most.
What we do is we include workshops every 1 month or 2 months of supervision. There is a workshop with somebody who is a professional, but not the supervisor, who's an expert in workshops, to talk about this, about the construction of themselves as therapists and their sufferings. We call it vulnerabilities and strengths of trainees in psychotherapy.
Yeah, very good. Yeah. we have this each semester. Yeah. Okay, so let's go on. So as you also mentioned, David Orlinsky, of course, we looked into the practical issues of the worldwide going on project concerning the qualification profiles. We had published, David Orlinsky, we published it in 2023, I think, David and Armin Hartmann, Thomas Schröder, and the qualification profiles in all 16 countries, we had the opportunity to get insight. They say that the reflective ability is the main topic that has to be cared for, and the interdisciplinarity. Also empathy, self-awareness, good mental health, and theoretical interest and intelligence. It was not the main topic. So we, of course, I think you all know the publication from the 90 programs in 16 different countries. We presented is in the SPR Congress 2022 in Rome. But every country has a lot of supervised treatment cases in their training program. They have a lot of supervision, but also personal therapy and an internship. And this is the second point. There you can read about I can send the PowerPoint afterwards if you want. I put in
Thanks.
the citations. For example, here is this so-called empathy lab described. This what I was explaining to Denise DeFay already, and before they come into a course, for example, they have to present. They have to go into an e-learning course. The students, for example, you can read it here in this both publications. They are summarized in the competence in this on the bottom. For example, they have to solve case scenarios, problems in the e-learning. So they have to present then their own case. So how they would how they reflect on this problem, how they would what would be the most effective approach for going into this topic and solving the problem with the patient, and their own attitude is. And after they have done the interactive questions in this e-learning, in these case-based blended learning lessons, they then go into the seminar. So it's like a flipped classroom. So the people have to go into the case. Of course, they can then write or read theory. They have also a literature group where literature is provided and where texts are read in several steps. So they also can discuss the theory. But the main point is that they have to combine the theory in their professional work and provide it in these case-based blended learning lessons, for example. And then Sorry?
Sorry, Henriette, could you give an example? Because this is interesting, the e-lesson, the interactive. What does it really look like with the flipped classroom? So
Yeah,
what are they exposed to before the class? What do they have to do? So
they only have a Moodle,
yeah,
a learning platform.
yeah.
They step into the Moodle course, and there, for example, they have patient A, they have a scenario.
Oh, okay.
Patient A does this, and he needs this and this, and he urges you to give he urges you to give this and that, or to write a consultation for something like that, and then they have to say what there are questions. So multiple choice question. What would you do next? So they have to point, and when the beginner, for example, doesn't reflect and says, "Yeah, I give the benzodiazepine. This patient is very anxious. I do not want to know why he's anxious. I'm supportive," and then they get an answer. That this is not the right, they should reconsider, is this really the right answer? So could it be another thing? So could it, and these are interactive questions.
Okay.
And then they have to create their own, after they have the opportunity to answer, and so there is no punishment. So this is not a questionnaire or something like a test situation. So they can use it as long as they have to use it, and then they have to create their own case situation or clinical scenario, and argue why they did a supportive intervention, or why they did a confrontative intervention, or why they restricted this, or why and then they have to provide their case vignette again to a peer group. So this is all only in this Moodle course, in this e-learning platform.
Yeah, okay.
And another student replies to the case and says, "Oh, this is not good." And they are, there is a discussion. And then when they have, they get a point, they get some, from the peer group, there is a scoring. And when the scoring reaches a certain level, then he goes into the seminar.
Wow. Okay. This is amazing.
It was, we built up this program from 2013. It was a hard work, but I think it's good. So
so there is a question here from Hannah Levinson. Is it okay if I, Hannah, do you just want to ask so I don't read the question, or?
Sure. This is all wonderful in terms of the learning experiences and the skills you wish to inculcate. I'm wondering if you see possibilities for using AI to really drive home intensively and responsively the learning you hope to achieve.
I think for example, here, the teaching of the scenarios. So as I talked, that in the e-learning, these scenarios or these integrated thematic instructions, they could be provided by AI, ChatGPT or what else. And the point is that it would be very necessary to look at the transfer from what the student does in this e-learning, for example, or what he provides in this, and what he is doing then with the simulated patient, and what he is doing then in the next step with the real patient, and what he's doing then after supervision. So there is no possibility to be outside the direct presence mode, but to be prepared, I think it's very okay to use AI.
Thank you.
So for this preparatory things.
Yeah. Mm-hmm.
Mm-hmm. So what I wanted, maybe we always, for example, maybe when you go into AI discussions, we have to also consider how can we test our students, and there we are doing in this direction that we have structured interviews. So it's so-called objective structured clinical examination. So we have 7 scenarios or stations, one for empathy, one to test the mentalization ability, one the therapeutic relationship, and then we also have 4 cluster-specific competences. For example, we test the psychoanalytic competence with the psychoanalytic core competency Q sort, or maybe some know the psychodynamic intervention list. So 2 raters are observing the candidate when he is interviewing a patient, for example, and then the psychoanalytic competence, the system competence, the humanistic attitude, and the behavioral therapeutical skills are observed, but also the more general 3 factors, and the 2 independent rater or assessors also think of the therapeutic attitude. We use the TAT score provided by Rolf Sandel, and there is also the facilitative interpersonal skills scale. It's very useful in my view to measure the ability if the candidate could establish a working alliance with the patient, or you can measure, we do it in this direction, the emotional resilience with the affect regulatory Q sort to get an insight about the candidate's affect awareness and affect regulation capacity, because the affective awareness is a very is the groundbreaking. It's a basis for good therapeutic work. So these are the assessment scenarios. Of course, this is also for small groups, so not for big university courses, but for small groups.
Mm-hmm.
I think I saw Denise Defay already.
Yes, you're also raising. You're right.
No,
Denise.
I want to first congratulate you, because I think this system of assessment is very, very complete. But what do you do when they have bad results? How do you manage it?
Yes, we talked. This is a good possibility to give feedback, because you can say you are good in empathy, you are good in the mentalization ability, and you're establishing a working alliance is lacking this and that. You should be aware of this and that, and maybe focus in your supervision or in the clinical practical work this and that, to not to intellectualize too much or not to rationalize, or go back to yourself experience, to your self-analysis. Maybe there are some difficulties concerning your own his life events or history, so you can give feedback to the candidate, and it's never we never have problems because it's an interactive thing.
But are they in therapy while they are studying with you?
Sorry?
Are they do they have to be under therapy while they are being trained?
They have to, yes. Everybody has, yeah. Everybody
But what
has.
you tell them, they can see somewhere else. They can discuss it with a therapist.
Yeah, of course. Okay.
Dan Sachs, and do you want to ask your question?
I'm actually putting my kids to sleep and listening while I am, so I'll just let you read it.
Oh, okay. So I'll read it. I'll read the question, and I hope your kids go to sleep. Hold it. Just 1 second. Okay. If supervisors regularly watch trainee videos in supervision sessions and give ongoing feedback on performance based on clearly chosen metrics, would that not be both cheaper and reliable? So the question is, do you actually need to watch them doing the role play and doing the assessment? Or Dan is asking if you can look at video sessions of the therapy, I guess. I don't know if you tape therapy sessions or.
Yes, I have compared two groups already, and the learning effects are we call it teilnehmende Beobachtung. So it's called accompanying observation. Do you understand what I mean? So when you look at a video, you have a very great learning effect. It's nearly the same as doing it on your own. It's
Okay.
it's not 100%, but it's over 80% on learning outcome. So it's not all, but it's for preparatory stages. We use also videos from first consultation situations, for example, or from our research projects. We are doing a lot of I am doing a lot of video research projects concerning interaction questions, and there I ask patients and their therapists if they provide it for training efforts also, and when they have given their informed consent, then I can use it, or the material can be used in training situations, and the students like this it's the first step to get into it is not, they are not so anxious, because sometimes they are very afraid to be in a group and be focused in the center of the audience, and then have to provide a good intervention. So it's sometimes stressful for the students, and so they like the videos, to start with the videos.
Okay. There's another question, if that's okay with you, from Madeline Rogers. Do trainees receive a certificate or credential post-training? What sort of certificate? Attendance, completion, certified? It's psychoanalytic psychotherapy, right? Or psychoanalysis?
It's we have different courses. The course, for example, provided at the university, where we have a course providing ECTS, so it's a university course.
Okay.
And there is a certificate from, a bachelor, a master's degree. They have to also write a master thesis then, and they get the degree of a master's degree of continuing education. So this is one possibility, and of course the society, the Society of Psychoanalysis, the WPV, Viennese Psychoanalytic Society, is of course giving their accreditation then in accordance with the IPA when the IPA standard is fulfilled.
Okay.
So there are different ways, because some do not have a master's degree and want to write a master thesis, want to go more into the research or into clinical research and do the master's degree in a clinical research question, for example.
Mm-hmm. Okay, I think we can, yeah.
Okay.
Yeah.
Shall I?
Yeah.
Shall I go on, or?
Yes, go on. Thank you.
Good. So the essence of all this work led to the situation that we did a lot of research, also this research study, for example, and this brought the new situation that we now have a new Psychotherapy Act, and there we had the situation that we have a lot of psychotherapists, and they should be trained more effectively, and therefore we now have 10 official universities working together in Austria, and there it is in this direction that a master program is provided with an entrance exam. So with a very official entrance exam, and when I go back to the situation from the Spreestad study, we found out that, for example, interviews with program faculty or staff are the most used assessment criteria for assessing the applicants in the small societies. This is not possible in a bigger situation. So we now go in this direction, that the entrance exam is quite strict, focusing on psychosocial competence, and there is a self-assessment before they can get towards the entrance exam. And in this self-assessment, the candidates who want to become a psychotherapist are confronted with real-world scenarios provided by very experienced psychotherapists. So we went into the field of knowledge of the very experienced psychotherapists, and we asked them how to characterize their work. So how would you explain your work to a young candidate? Something like that. What do you like? What are the difficulties? What are the good things to be a psychotherapist? And out of these gatherings, we created some kind of a self-assessment, and this self-assessment is given to candidates who want to become psychotherapists, so that they have an orientation. I think this is a necessary thing, because when you buy something, you want to see what you buy. And
that's true.
and this is also my experience in medical education, that for example, for a long time I coordinated the 4th medical year, and in the 4th year the people get the medical students, they get into their context into contact with the patients for the first time in Austria. And some say, oh God, I don't want to become a medical doctor. I didn't want to have this stressful situation with patients. I never thought about this, that this would be medicine. And then they can orient and go into pathology or into another. But it is quite late that they see what the occupation really brings. And this was the reason that we now put this self-assessment, this kind of to provide all these things what candidates will then expect in their occupational life, that we provided from the beginning on. This was I think this is a good decision to see if they really want to. Of course, the empathy, self-awareness, good mental health can be tested, resilience factors, and the internship is compulsory now. So people have to go into an internship. This is not compulsory in the worldwide. When we looked into the training programs worldwide, it is not compulsory in each country. But I think it is very necessary, because this clinical training and to have this approbation exam is maybe the last point what I want to talk about. That after the internship, our candidates have some kind of approbation exam now. This is a situation that they have to write a case,
like a summary of the treatment.
Yes, of a
Case
treatment.
summary.
Yes, case
Okay.
summary. Thank you. Yes, and of course they have to put in theoretical considerations why, for example, for diagnostic reasons, they took Kernberg's scheme of borderline personality disorder, borderline personality functioning, etc., etc., and then the society has to give okay to this case summary or case theory compendium. And after the society has given the okay, they can go to an official from the Ministry of Health, a bureau, and there a commission is testing the candidate, and this commission is consisting of 3 different schools, at least 3 different schools. So they have to be a behavioral psychotherapist, a systemic psychotherapist, a psychoanalyst, or a psychotherapist from the humanistic tradition, so experiential or Rogers client-centered. So this is then the committee, and they provide the questions and ask the candidate.
Okay.
And also there has to be a psychiatrist, a clinical psychologist, and a psychotherapist. So all the ground professions, because till now in every country the most training programs were set up on the second career level. So till now the most people have a ground profession.
Okay.
Mhm.
Let me see, Denise, I'll take 1 second just to see if someone else has a question. Okay. So we give other people the opportunity. Anyone? Okay, go ahead.
Just a question,
Yeah.
because there were in the committee assessing the trainee for his diploma, final diploma. You said there were therapists from 3 different schools. Are students learn these 3 schools, or they learn one and have to have certain ideas about the others?
They have a master's program, and in this master's program there are all 4 schools provided in basic learning objectives. So not on being able to giving a interpretation, for example, what is necessary at the end. So you specialize in one tradition, but you have to do in your master's studies, in the master's program, all the traditions. So you have to learn, for example, even if you are a psychoanalyst, if you are trained and in the 3rd phase of the psychotherapy training, we have 3 phases. We have the 1st phase, the 2nd phase. In the 2nd phase, the master's phase, there is the situation that you have to learn all 4 traditions, but you do not learn the technique, for example. So how to conduct an exposition therapy or something like that. But if you then want to get a behavioral psychotherapist in the 3rd phase, then of course you have to learn what the state of the art of the cognitive behavioral therapy is teaching now. But for me as a psychoanalyst, for example, I do not know how to do a
like exposure.
Yes, exposure therapy.
Exposure for the CBT. Yeah.
Yeah.
Okay, I see that there is another really interesting question. One, so thank you for an interesting presentation. He writes, do you have data regarding which skills are easier and harder to learn from candidates? And also, I would be really curious, do you build more basic skills, or do you find that there are some things that are more difficult for them to learn? So, yeah.
Yes, I have provided, I thought that you were asking in this direction, and I brought my study concerning reflective functioning, because we looked at what is the problem with severely disturbed patients. We are often not in the situation that we can help them. So we went into acute psychiatric ward, and this is group C, for example, and we measured the mentalization capacity with the reflective functioning score. So we did the brief reflective functioning interview with the psychiatrists, with the psychotherapists, with the nurses, with the whole staff in the psychiatric ward. And when you look at the median
Mhm.
it was quite low.
How was it assessed? How was reflective functioning measured?
With the brief reflective functioning interview, so you have the scale from -1 to 9. So this is the RF score according to -1 would be hypo-mentalizing. So a borderline patient would be around 2.
Mm-hmm.
A normal, for example, here are the group A are the psychotherapists with over
More than 5 years.
in clinical practice. They have a reflective functioning score of 7. So it's, and the normal people, so also when they begin, the candidates at the beginning of psychotherapy training, at the beginning of the training, they have an RF score of 6. So between -1 and 9,
not so bad.
It's not so bad, yes. But we were very astonished that in the psychiatric ward, there was quite a low RF score, and we provided then MBT training, because it's not good to stay with this score. We wanted to.
Wait, who is in group C? Who are the people in group C?
Psychotherapists, psychiatrists, nurses, all the staff of the psychiatric ward.
Okay. So they have a low mentalizing score? That's what you're saying? Wow.
Yeah.
Okay.
And this we couldn't accept. So we talked with Svenja Taubner and with Martin Debanet, and we went to consult to Sebastian Euler and all the people around who are interested in MBT training for working with psychotic patients, for example, or severely ill people. Provided MBT training, and it's ongoing. And after 1 year, for example, their RF score got better already. So what does this mean? Or we also looked more in the details, because we wanted to know who are the one who are not able to mentalize. And we found that it was interesting when we compared the occupational groups, that this was the medical doctors, the psychiatrists. The green bar are the non-doctors, so the psychologists, the social workers, occupational therapists, the music therapists, and the light blue bar are the nurses. And of course, we went in interviews then and qualitative research, and we found out that the problem is that the nurses are too, the distance between the patient and the nurses is too dense in a psychiatric ward. So they are there are also bodily attacks sometimes
okay.
And for the non-doctors, they have they can provide a date. So they say to the patient, my occupational group or my music therapeutic group is on Thursday, 10 o'clock. Please come in this. And this gives a distance.
Yeah.
And a possibility to reflect again. And you are not so under fire, under affective fire. And this was the reason that we then trained the staff, the whole staff, with an MBT training to get more distance to the direct negative affectivity or intense emotions, and to help the staff to be in an mentalization capacity and to get back to a reflective functioning.
Yeah.
So for training, it would be the same, because you asked what is the thing, what is the hardest thing to be trained. I think that you do not lose the mentalization capacity, because it can happen. Circumstances can occur that you have to work on under fire, and the best you have to take care of is that you keep your reflective functioning.
Mhm. Wow. Okay.
And because
Yeah, go ahead.
this is so necessary for, does this answer your question a little bit? Does this
Okay,
answer
I'll just take the next
Does this
question if
answer-
that's okay.
Yes.
Sorry, I lost the signal. Yes, it answers the question. Thank you very much.
Okay.
Very
Thank you.
interesting.
One other question. How does this training model work for patients who are non-responsive to psychotherapy? Because you're describing empathy and a therapeutic relationship, and Grace, who asked the question, was how does this work for non-reactive patients that don't respond to regular therapeutic interventions? So these are the more challenging patients. Okay. Henriette, are you with us? Or she may have lost. Oh, okay. Did you hear the question? Okay. I'm wondering if we lost her. Okay. No, she's here. Henriette, are you with us?
Yeah, I'm here again.
You're here. So the question was, how does this training program work for patients who do not comply, who really don't respond to all these interventions?
This was also a question where we went into with this video research concerning the micro expressions, and there we found that when the negative, when this was very directly in form of a
We can't hear you very well.
Interpretation, and not only supportively. Do you?
Your connection is unstable, I think.
Do you hear me again?
Yes, now we can. Now we hear you.
Okay.
Okay.
So the better the psychotherapist could address the negative effects in a meaningful way that was meaningful for the patient and his life history or his life events, the better the Working Alliance got. And this has to be trained in this direction, that the candidates have to be aware of their emotion, their affect. So the effective awareness, or the level of effective level of emotional awareness has to be trained.
To be aware of their own emotions, of their own emotional reactions.
Yeah.
Okay. So this is part of supervision.
This is part of supervision, yes. And for example, because you asked concerning AI, for example, we have transcripts, and with AI we could figure out groups of word constellations, which are level 1. Maybe you know the level of emotional awareness scale. It was developed by I come to his name. He was in Vienna last year, and he
level of emotional awareness. I'll see if I can find it. Okay.
Level on, and there are 3 levels if you want. So the first level, if a patient only uses very concrete word, so you can train this. And if you provide this to the candidates, they like this training program. You have to be creative, and there you can use ChatGPT, for example.
So how do you train them for emotional awareness? What do you do?
For example, our exploration videos are the training videos. They are transcribed, and we look how then the next candidate comes and has to explore a patient for diagnostic reasons, for example, and we look what word and how much level of emotional awareness is there, and we found that the higher the level of emotional awareness was, the preciser the diagnostic was.
Wow. One thing that I found, the first author is Richard Lane.
Yeah, it's Richard Lane. Yes, of course.
Okay.
Yeah.
So thank you.
Thank
So
you.
it's called, no, I just looked it up in Google Scholar.
Yeah.
I'm learning as you talk. It's called The Levels of Emotional Awareness Scale, a cognitive developmental measure of emotion. And the first author is Richard Lane. Okay.
Yeah.
Thank you. We have a few more minutes only, so I'm wondering if we should take questions, or do you want to give us a little bit more before we end? Whatever works for you.
If I should go into something, if there is something open, or if you came into this webinar with a specific intention, what I did not fulfill now, this would be open for me.
Okay. So we have like, maybe 10 minutes. If people want to ask questions that Henriette didn't address, or something that relates to training and supervision, this is your chance. Yeah, Juan, you raised your hand. Yeah.
Good evening, good morning, or good afternoon, everybody, depending on the place
depending
of the world.
Where we are.
Thank you very much, Henriette and Ms. Pierre, for this webinar. My question is regarding your experience implementing this kind of training. I am thinking specifically about our Argentinian context, and one context I know more closely is the Buenos Aires Psychoanalytic Association, and I'm thinking about psychoanalytic associations and how to implement this kind of training, which is not the traditional training that psychoanalytic associations here in Argentina tend to use. So, do you have encountered some obstacles? It's something very local of Argentina, and it doesn't work that way in other parts of the world. I just wanted to your feedback on this topic. Thank you.
Sorry, there was a phone call. The last question, could you repeat it again? Sorry, I didn't.
Yes, my question is if you have any experience finding obstacles to implement this kind of training, because I am thinking about the traditional psychoanalytic training. I am speaking knowing my context here in Argentina, and I think that here in Argentina it could be something difficult to implement, because maybe it could be seen as something to, I don't know, videos, emotional experience, and I imagine people saying that's not psychoanalytic treatment.
Yeah.
What do you think about it? Because I am interested in implementing that kind of things here in Argentina.
Yes.
That's why.
Yeah. Of course, this resistance was the same here, or is the same. And I think what we could show is that we only do describe the things what old psychoanalytic schools always did, working in small groups, providing text, Freud text, and Bion, and of course Melanie Klein, and essential works. And what we make more transparent is how we train it. We make the training progress more transparent, but it's not removing the old tradition. So it's only bring transparency into the well-established thing. And in this kind, Kernberg helped a lot, because in Austria we lost a lot of psychoanalysts in the 1938, and we had to reintegrate, we had to we had Anna Freud came back in 1971, or Otto Kernberg came back in the 80s and 90s. So it was a possibility to show what's going on worldwide. We also went to London and fetched and invited Betty Joseph and Hannah Siegel to come to us, and I had supervision with Hannah Siegel, and we in this training model I now provided, I only make transparent what we did in Hannah Siegel's supervision session. So it's nothing to of course it's quite structured, but I am working as a university teacher, so and I'm also responsible for grades as a dean, so I have to provide something structured, so that I can say this candidate has to get the feedback that he's not, this is not enough till now. He has to do this and this and this. And in your university context, you have to be transparent, because it's official money. It's an official medical school, so the people in Austria would be they have their right to know what we are doing in training. So this is the reason why I have to be where we have to be transparent, and this argumentation was convincing.
Yeah.
Thank you very much.
Yeah, we almost have to end. I think what you're saying is very, very important. I spoke to you just before we began on how I see a lot of psychodynamic supervisors here in Israel train our students. So in the courses, they learn a lot of theory. They learn Freud and Klein and Winnicott. So they have some theory, and then they come to their training sites and they say, well, just go in and do therapy, and they get lost. They have this vague idea that psychodynamic treatment is very, very complex, but they don't know how to connect what they learn in class. And I think what you're describing, it's not just transparency. You're really identifying what are the core skills and how to train and be better at them. And I think this is something that we sometimes forget. It's like we're not natural therapists. Yes, we're empathic, we can reflect, we have certain qualifications. But when you break it down to competencies and you assess them, and so I found that very interesting and refreshing, and I want to thank you. I think the webinar will be on the SPR website pretty soon. And
Perfect.
you said you'd be willing to share your PowerPoint, would you?
Yes, I can send this, what I have put together. Should I
Yeah.
send it to you, Oria, or
I
where
don't
should-
think so. Either Galit or whoever's, send it to me and I'll make sure it gets to whoever it gets.
Oh, I post it where we
Yeah, where we were writing the
okay,
emails.
yeah.
Okay.
Perfect.
Thank you. Thank you, everybody, for joining us.
Thank you for the invitation and the possibility
Thank you.
to.
Thank you, Henriette, and I'll see you in Bristol in person.
Yes, I'm looking forward to Bristol also. Thank you very
Bye-bye.
much.
Thank you very
Thank you.
much.
Bye-bye. Thank you.
Pleasure.
Thank you.